All right. So you ready?
Yeah. Yeah.
All right. So let's do. Wait, hold on. Somebody's texting me. Uh, okay. All right. So let's go to number three.
All right.
So you did a TAH-BSO on this patient. I see that it's only 69 grams. Why did you do a TAH on a 69 gram uterus?
So this patient presented with an incidental find or with postmenopausal bleeding and ultrasound indicating hydrometra. Based on the ultrasound reading, I attempted to do an in-office endometrial biopsy, however, was unable to identify her cervix. Based on palpation, there was no true dimple. I prescribed vaginal estrogen. We tried again 2 weeks later, again, was unable to identify the cervical canal. And for this reason, we did the abdominal hysterectomy, as I did not feel that I would be able to find accurate planes for a vaginal hysterectomy.
Okay. Were um were you able? Did you not do any type of sampling before you took her to the operating room
I
for the
attempted
T?
twice and was unable to.
What about like a hysteroscopy DNC?
Discussed it and considered it because had been unable to identify where the cervix was and had called one of my colleagues into the room to see if a more senior physician was able to. We thought that it may be an unsuccessful procedure, and the patient was eager to hysterectomy secondary for the concern for cancer.
Okay. All right. Let's move on. Number six. Uh, so I see that you did a over one on this patient. When do you get an over one?
So I do an OVA 1 for any patient 18 years and older with a complex ovarian cyst that I know we are going to operate on to help determine high risk, low risk for ovarian cancer.
Do you think a 24-year-old with a cyst is high risk for cancer?
Generally speaking, no in this age group. However, the OVA 1 is indicated for 18 years older with complex ovarian cysts that you know you're bringing to the OR.
Okay, so anybody with a complex adnexal mass, you would do it over one.
If we had decided on surgery. The benefit of the OVA 1 is it allows surgical planning either by myself if they're low risk or referral to gynecologic oncology.
Okay. So I see this MRI was done on this patient. Did you do an ultrasound?
Yes, we initially had an ultrasound, however, secondary to the length of my list, I did not want to inflict further words, but yes, it was initially an ultrasound showing complex adnexal masses.
Okay. So the ultrasound was done before the MRI or after?
Correct, before.
Okay. And so why did you do an MRI afterwards?
Ultrasound showed a complex adnexal mass, however, was unable to further characterize it. I wanted better characterization of the size as well as so that for surgical planning, essentially, I wanted to see whether it was uterine mass or adnexal mass versus ovarian.
Okay. So patient number nine. So this patient was a postpartum tubal ligation. Um, what's the what's the risk of a pregnancy after tubal ligation?
For a Parkland partial tubal ligation, risk for pregnancy is 3 in 1,000 at 5 years.
Okay. And is that what you used to?
I do a Parkland for my postpartum tubules.
Okay. Patient number 10. What is a, so this patient had a endometrioma essentially. Is there any type of characteristics on ultrasound that you will be able to see, identify an endometrioma?
Yes, so for an endometrioma, it can be described as a lacewing pattern, complex ground glass appearance.
Okay. And then was, this patient's 29. How did you counsel her about fertility?
So this patient, we discussed that a cystectomy would have no impact on her fertility and that one ovary would be as effective as two when it comes to future fertility. However, with the diagnosis of endometriosis, there's concern for scarring, which can lead to decreased movement of the fallopian tubes and can decrease fertility.
Okay. I didn't see, so was this patient having any symptoms?
Yes, this patient was having intermittent pelvic pain with concern for torsion, however, was not torsed at the time of the surgery.
Okay. So you did the surgery because she was having pain, not because she just has a complex mass.
It was a part of it. The patient was also concerned for endometriosis after discussion of the appearance of the ultrasound as well as the intermittent pelvic pain.
Okay. So if she had no pain, would you still offer the surgery?
We would discuss it. Initially, we had attempted ultrasound monitoring. It had increased in size over 6 months, and that combined with the intermittent pelvic pain. But initially, we attempted ultrasound monitoring.
Okay. All right. Patient number 11, also a complex cyst, and the ultrasound showed. So, why was a DNC done on this patient?
This patient was having abnormal uterine bleeding, um, and the ultrasound showed the 1 centimeter endometrial thickness. While there's no normal within a menstruating female, we discussed the abnormal bleeding pattern, the fact that you would already be asleep, and that we could sample the endometrium to make sure that there were no polyps or risk for endometrial cancer, as the patient would already be undergoing surgery, and we identified an endometrial polyp.
Okay. But if you had any concerns for any endometrial pathology, wouldn't a in-office endometrial biopsy be less invasive?
Yes, however, under 35, she did not have several risk factors for endometrial cancer. I did not have a high suspicion, but I felt that it was reasonable with our discussion of counseling on risks and benefits of in office versus while she's under anesthesia performing the procedure.
Okay. Patient number 12. Um, was there any type of conservative management done on this patient?
So, with this patient, she had presented after care with another doctor and had already attempted oral contraceptive pills and had failed, ongoing pain, dysmenorrhea. Um, we discussed doing a hormonal IUD. Our patient desired definitive surgery to confirmed the diagnosis. And so that combined with the ovarian cyst, we proceeded with surgery.
Okay, so it looks like you did find some endometriosis on this patient. How how do you report endometriosis findings? Or is there a
Can
system that
you,
you use
do you mean in regards to or
on
laparoscopic
surgery during surgery?
surgery? What I am looking for are the powder burn marks, the stellate windows. If I see implants that appear to be endometriosis, however, are not in a place for me to biopsy, I'll take a picture so that I can inform the patient. However, otherwise, I will try to excise an implant for so that I may send it to pathology.
Are you aware there if there's any type of staging system for endometriosis?
Yes, this patient had a stage 1 condition.
Okay. So stage one. Um, how does the stages correlate with patient symptoms?
I believe that the stages do not correlate with the symptoms. Some patients will have severe pain with a stage 1, and some patients could be asymptomatic with stage 5.
Okay. All right. So let's continue. Patient number 13. Um, let's see. So she had a left salpingo oophorectomy. So this patient is 67. Was there a conversation about taking out her other ovary?
Yes, there was, and it had been a part of the original plan. However, there was scar tissue around her right ovary, and I did not feel that the benefit of trying to remove the ovary outweighed the risk of injury during surgery.
Okay. All right. So let's see. Let's move on to patient number 15. So on the ultrasound, it says there's a 9 centimeter ovarian cyst, but I don't see that on your pathology. What happened?
Great question. On the ultrasound, there was a 9 centimeter ovarian cyst. When we proceeded with the laparoscopic procedure, there was a 2 centimeter cyst. She had desired surgical management, so I did remove it. However, we had repeated an ultrasound, it had maintained size, and it ended up being 2 centimeters.
So you repeated the ultrasound before the surgery and it was still 9 centimeter. And then you took it to the OR and there's only a 2 centimeter cyst.
Correct.
Okay. What do you think happened?
I think it was most likely a corpus luteal, or the ultrasound had perhaps captured a fluid-filled packet. I'm not entirely sure.
Okay. And did the ultrasound characterize the cyst like complex, simple? Oh, you said simple.
Visible.
Simple. Okay. So I see that over one was also done on this patient. So not only complex ovarian cysts you do an over one, even simple ones.
Generally, I will only do OVA ones. However, this one, as it was approaching 10 centimeters, I did the OVA one based on that.
Okay. And then I see that there's a frozen done. Why was there a frozen done?
This patient had declined an in-office endometrial biopsy, And I had the opportunity to send it for frozen as we were in our main operating room as opposed to the surgery center, which does not grant me that ability.
Okay. So having the frozen, how would that change your management?
Scheduled for an endometrial ablation. I had counseled the patient that if we had done an ablation without endometrial sampling, that it could hinder endometrial cancer staging. And so while having the tissue, even though frozen is not an ideal surgical specimen for analysis, it does give us that ability to uh, at least feel reassured that I would not be increasing her risk for pain management for an endometrial cancer.
Okay. So what's the percentage of a frozen, detecting malignancy on a frozen? I'm sorry?
Next question.
Okay. Patient 19. Uh, so this actinomyces were found on the pap smear. Um, so let me see what. Just can you tell me a little bit more, a little bit about what happened with this patient?
So this patient had come to our office with a retained levonorgestrel IUD. We had an ultrasound confirming intrauterine placement, so we proceeded to hysteroscopic IUD removal and DNC. We also desired new levonorgestrel IUD, so we replaced that. I had sent the initial IUD to pathology for analysis, and they had identified actinomycetes-like organisms um, and mild chronic endometritis on the endometrial specimen. So for this patient, we discussed that she had been largely asymptomatic, but we did a short course of doxycycline to decrease any risk for abnormal bleeding that can be seen with actinomycetes or PID.
Okay. I see that the DNC was done for this patient, and she has no abnormal uterine bleeding. Why was the DNC done?
The patient, yeah, I don't know. I don't know what I'm gonna say for this. BSing my entire way through. I have no idea what I'm gonna say for that.
All right, we'll figure something out.
That's it.
Okay, let's keep going. IUD. Okay, so let's say you found actinomyces on a pap smear, and patient has an IUD in. What would you do?
It is not, if the patient's asymptomatic, it is not an indication to remove the IUD. However, I would treat the actinomycetes.
Okay. Uh, Patient number 23. Okay, and then this one also had a DNC. What was the reason for the DNC?
We were not sure if she had further polyps within her atrial cavity. I was able to identify a cervical polyp in office. However, I was unable to identify patient was concerned that there could be another polyp further in her uterine canal cavities, which is why we performed the hysteroscopy. Um, I did not identify any polyps at that time. However, patient had desired sampling and was high risk of concern for cancer, so we performed sampling.
Okay. All right, let's go to patient 34. Uh, so this patient had a unsatisfactory pap smear. HPV was negative. What would you do with this patient?
Patient over 42 has a single sexual partner. We discussed that while pap smears are Ideally, present both the scripture for the cytology as well as the presence or absence of the HPV virus. HPV negative by itself could be treated, followed with a pap smear in 5 years.
Okay. Uh, all right. Last question. Patient number 36. Um, what is the classification for a leiomyoma?
The classification is for this leiomyoma
No, just in
or in
general.
general. In general, the classification of leiomyomas is between grade 1 and 7, indicating their position in relation to the cavity to the serosa.
Okay, can you give me a little bit more specific?
So I would want to double check, but I believe that grade 1, 2, and 3 are abutting into the cavity, while 4 or 5 are within the myometrium, and 7 is subserosal.
Okay. All right. That's it.
Man, you're gonna be so impressed when I'm closer to my exam and not at the very beginning.
No, you're good. You have a lot of time to study. Don't worry. It's
Can
just
you tell I'm bullshitting? Because I don't know any of my patients.
does it matter? I can't tell actually. It sounded like you knew them, which is totally
Good.
which is good. Yeah.
I was only off by 1 for the grading for the fibroids, though.
Yeah, I think well, it's
Well,
0
it's
to 7 actually.
0 to 8.
Oh, 0 to 8. Okay.
Apparently, there's an other non-specified, which is like cervical and parasitic.
Oh, right. Yeah. Yeah. And
Um,
then 1 to 3 is well, 3 is touching the endometrium but in the endometrium, right? Or in the myometrium. Or
yeah.
am I wrong? I forgot.
It's, yeah, I have it up right now. 0 is pedunculated
Uh-huh.
intracavitary. 1 is more than 50% into the cavity. 2
2 is
is
less
less than 50%. 3 only contacts the
touching.
endometrium
Yeah, touching. Uh-huh.
and intramural. And then 4 is intramural. So 3 and 4 are intramural. 5 is over 50% intramural. 6 is less than 60% intramural.
60%?
50.
Oh, 50. Okay.
6 is less than 50. Yeah.
Oh, okay.
Um, what uh what is the detection rate for frozen?
I don't know.
Okay, cool. Yeah, like
We'll have to look it up. I just like
yeah.
thought
Well,
of it
also
because
yeah,
you
no,
know.
that's a good question.
No, but
Um,
since you had it on your list, I would know it.
I know I am gonna know it. I
Yeah.
think they asked me that, and they also asked me the like, what's the age for bilateral oophorectomy, which is 65, right?
Uh-huh.
Okay.
Yeah.
Keep um keep gaslighting myself. And being because my partners do it at 50.
Oh, no, that's the old thinking.
That's what I thought. What the
Yeah.
fuck?
Yeah, before
Um,
65, the ovary's still producing a
a
tiny
little
bit
bit.
of, yeah. Mm-hmm.
Still supposed to be helpful.
Yeah.
Um, yeah, that's the questions that I have to answer is like that they had the exam pro was the same thing. Like, why did I do a D&C on a 25-year-old?
Yeah. So,
Honestly, and this is truly why I did an EMB on a 21-year-old who had an ultrasound that said they couldn't rule out hyperplasia and it was cancer. So now
wait. So, what happened? You did an EMB.
21-year-old. This is
Uh-huh.
like my paranoia thing, and it shouldn't guide my practice, but it does. But I did an EMB on a 21-year-old because the ultrasound was like, can't rule out hyperplasia.
Oh,
Um,
ultrasound can rule out hyperplasia?
yeah, the ultrasound was like, can't rule out hyperplasia. Like
Okay.
it's a complex like endometrium, so I did an EMB on her, like kind of just
But
as
did
like a
she have
whatever.
any risk factors?
Yeah, she was obese. She had like a
Yeah,
BMI of
there
40.
you go.
But
So, yeah.
1. So now it's like at 25. I'm like, well, fuck, okay. You're gonna be asleep anyway. I may as well do it. Can't
Yeah,
say
I
that.
mean, yeah, I mean that's not the best defense, I feel like.
Oh, it's
Yeah, might
not.
as well, yeah, you're asleep, might as well do all the different things, but it has to have, because they're gonna be like, okay, what's the complication for a, whatever you did. Um,
See, I
right.
know. But that's
Yeah.
like generally speaking, if I have a patient with abnormal bleeding and they're asleep, I do a D&C. Why wouldn't I?
Yeah, I mean, well, might as well.
Yeah, but I don't know what like how to defend that.
Mm,
Um,
maybe that's something
and
you can ask the exam pro
then,
people.
yeah.
Anyways, oh,
Um,
let's go over the questions real quick. Let's see. So I mean the TAH thing that you said is pretty good. I mean, as long as you have a good reason for it. So I don't know about you guys, but like my partners, they've been practicing for a while, so they don't even put like a uterine like cup onto
later,
the uterus onto the cervix. They just put like a freaking um like a sponge stick in there.
if I've done that. She didn't even have a cervix. Like it was literally flush.
Oh,
Like
I
it
mean
was,
she
there
is
was,
78.
yeah. Like I literally called in one of the other doctors. I was like, "Do you see a cervix?" And she was like, "No." I was like, "Okay."
Yeah, I
And then it
mean,
was so small, I could barely even feel it. So, so I was like, "All right,
yeah, I
I'm
mean
sorry."
as long as you have a good reason for it, it's fine.
Yeah.
But I'm pretty sure they're gonna ask you that question,
Yeah.
because that's
No, it's
like,
fine. Yeah.
okay. So the
I think
over, go ahead.
couldn't find the cervix, and so that I didn't feel confident I'd be able to find the plane, I think is reasonable.
Yeah, no, no, it's totally reasonable. It's just you need to have a reason. Yeah. For the over one, um, I don't know obviously I don't know the answer to that, but
I do actually, because I looked this up because it was a part of my exam pro thing. They were like, "Why are you doing so many over ones?" Like on
yeah.
his thing. And so during the course, that like last day with like the questions, like I asked the guy, I was like, so the practice bulletin with the management of adnexal masses, it's about that there's no true benefit of doing a CA 125. However, you can do the multi variable immunoassays. You are planning on to go to surgery because it can help you plan whether or not to refer to gynecologic oncology. And the indication is over 18 and planning to go to the OR.
Okay. Um, that's true, but also like, cause, cause I don't, cause they always talk about like, overutilizing things.
Resources? Yeah.
Yeah, so like, for example, that simple cyst, you also did a over one. I feel like that's a little bit overkill, but just, you know, just be prepared that you have to answer. Like, they might ask you for about it.
And I think that that one, it's close to 9 centimeters. It's embarrassing it came back at 2.
Yeah.
Like, I remember
I
doing
was like, what the fuck?
I did the case and was just like, what the fuck? But also, like, do you guys have Center Lake imaging?
Had a what?
Do you guys have Center Lake? Like, do they go to Center Lake for your patients?
No,
Center
no,
Lake is the
we don't do.
ultrasonography or the radiology centers that we send to, and they
Uh,
are,
horrible.
yeah. And so it's like, cause our ultrasonographers are garbage. I don't know what to tell you, man.
Yeah, and also they like they're starting doing the ORAD categories. I don't know if you have seen that before. It's almost
Oh,
like,
I'm gonna be on this.
I don't know, but like you know what it is, right? It's just basically ovaries, but like it's like BIRAT but for ovaries basically. So it's like, one, two, three, four.
Yeah, ours
Um,
are doing that.
yeah. Like I'm seeing it here and there. It's not like consistent. Some radiologists just use it, some don't. And also I've seen only like the easy ones. Like I've only seen like over ORAD 1 or 2 cuz like anything above that, they just, they don't want to say cuz
Yeah,
they don't want to commit.
like that's
So,
quite the thing to like commit to without pathology.
right. So
You
So
can
I
biopsy.
don't know how much of that they're gonna bring up, but I would, cause it's like a new kind of like a new system. I would still know it, cause like up to date, that's how that's what they use to like differentiate, or like it's, how up to date they like to use algorithms. So that's what they use the ORAD system to, like, to say, oh, it's if it's like ORAD 1 to 3, you don't have to do anything, but if it's like 4, then you get like CA 125, and blah blah blah. So I would just at least be
No,
familiar with it just in case. But
doesn't look like ACOG is using it, but yeah, it's been described.
yeah, but like, they might have like a structured case for where they will use it. Um,
Yeah.
but just FYI.
Call, thank you.
Okay. I think the postpartum tubal at 5 year, I thought it was 6 out of 1,000, but I mean
Might
three
be
or
right.
6.
Hold on. Yeah, let me what do I do? Parkland. Hold on, let me find it. I think I have it in my notes.
I don't think they
Uh
differentiated between the different types. It's just like postpartum in general is 6, but
um yeah, let me see this real quick. I know in our consents in let's see. It said 3.
where did it say 3?
Residency on the consents.
Oh, it does.
But that was residency. Like that's not
Oh,
what I mean, like that's not a
yeah.
thing. Um
Let me go to up to date real quick. Post. That's usually the fastest. Postpartum tubal. Uh, postpartum tubal. Pre-op. I'll look it up later. But let's keep going. Yeah, so the endometrioma, you said it pretty well. Um, so the exam pro guy said that if it's less than 5 centimeter, and if patient has no symptoms, usually you try not to remove it because it can actually decrease the fertility. That's what the guy said. I don't know how true that is,
yeah.
but
Um,
just letting you know. That's what he said.
and yeah, it looks like postpartum partial salpingectomy is 6.3 per 1,000 procedures at 5 years.
Okay, so 6.
Yeah.
Where'd you find that?
Medscape?
Okay, that's fine.
Yeah.
All right. Okay, so 6. Did you hear what I said earlier about
Yeah,
the?
about the decreased fertility.
Yeah.
I'd have to double check that.
Okay. I was just listening to one of the lectures that we're supposed to watch, and the guy mentioned it. All right. So 11, we talked about all the DNCs that you're doing. 12, conservative management. Okay. So the stages of endometriosis, um, so it doesn't correlate with patient symptoms, but I think up to date said that it can predict the prognosis of your infertility treatment.
Yes. Yeah. Stage 5 is bad.
Yeah. Is there stage 5? I thought it was just 1 to 4.
Other 5. Nope, it's 1 through 4.
Okay.
What's gonna be really annoying for you is when you're done with your boards and I'm like, hey, you wanna still do this?
Yeah, I'll help you.
Thanks.
Might not be as
You,
often, but I can still do like maybe
yeah.
weekends.
Yeah, it'll be,
Yeah.
yeah, exactly. Like once a week. Because also I'll be
Yeah.
doing the exam pro thing.
Right. Right. Um, let's see. Patient. Which question are we on? Oh, 15. That's the 9 centimeter cyst. Wait, 15? Yeah,
Yeah,
9 centimeter
yeah,
cyst.
fine.
Yeah, we'll have to find out the frozen.
Honestly, I don't know if I did repeat her ultrasound. Like, I don't know.
I I would probably not say that because it doesn't sound good. That
Or, yeah.
yeah, you just leave it at that. Like it was 9 centimeter, but when we took her to the OR, it disappeared,
Like,
which
it's
can
like, yeah, I
happen.
don't,
Yeah,
yeah.
but I think for this case, the more concerning thing is the frozen. Like because like frozen, like I don't know what the percentage is, and also like if it's positive, obviously you're not gonna
You're not gonna
continue,
do the abortion. Yeah.
right? But
So,
negative, being negative, like is it really that reassuring that it's negative? If what if it's like 50%, you know?
well, I don't think it's that. I think it's like closer to like 85, but the other problem is I have enough patients that have declined
The EMB before the endometrial
that
ablation.
it's almost nice that I had one that I got to do a frozen on.
Right, but also like that's not the best
Guideline.
way
Evaluate. Yeah, I know.
yeah. So it's like okay, either you're not doing them, but then the ones that you did a frozen on it. It's like that's kind of not the best way to do.
I think, no, I know. I think the bigger thing I'm gonna have a problem with is I have hers are frozen and I have others that I don't have as frozens that I did the DNC, then the ablation, and just got the path back and it happened to be benign. Um,
Right,
And
but
so,
I remember you talking to the exam pro people about it. But you also
and s-
said because like those are done at the surgery center, right? That's why you can't
and
do it.
yeah, I can't usually send frozen. This one, because her insurance covered the main OR,
Right.
was able to send it for frozen.
Yeah, but the thing is like let's say oh everybody's insurance covers the male, or are you gonna do frozen just on everybody who's getting an endometrial ablation? That's also not the right management
They don't
too.
let me. I know it's not, but if they don't let me do an in office, like that's what's so funny is like I
Yeah.
don't like yeah, it's not great. I don't know what to do about that.
Yeah,
You
I
know,
don't know.
but yeah, I don't know how. I don't know exactly how I really
Yeah.
what I said for to the guy to what's his face Shamrock
Mhm.
was I recognize that this is not preferred and it's not my general standard. However, this patient declined an office biopsy, was aware that lack of prior sampling could damage our ability to adequately and accurately treat endometrial cancer. However, she continued to decline in office sampling. So, because I had the ability to send it for frozen, I took what was available to me. However, I recognize it's not the best and it's not my standard.
Okay. There's also a ACOG committee opinion about like I think it's called like benevolence, justice or something. I think it talks about like patient autonomy. So you can like maybe read that one real quick and just see if there's something you can use from that article to, it's basically patient autonomy, right? Like you told
Yeah.
them the risks, they don't want to do it. I mean, like what are you gonna do?
Okay. Yeah. Also,
Yeah.
on this patient, even funnier, ordered an MRI and it still showed a cyst that big.
Oh, all right. I mean, and then it's gone.
It's gone.
What are you
Okay.
gonna do? I mean, that's why they tell you you can watch these. But yeah, that's another thing. Like, oh, she have abnormal uterine bleeding. So yeah, for this one, you can also mention like, oh, like offered observation,
Yeah.
then she declined, blah blah blah. All right.
Are you
19.
okay? Right, hold on. Are you okay? No, that's okay. All right, I love you. I'm just glad you're okay. All right, now we're good. Ian made a very big alarm noise, so I thought that he was hurt, but he's not hurt. Just- he burnt something, but that's fine.
Oh, okay.
Um,
All right. Patient 19, actinomyces. So yeah, so I actually looked it up. If the patient was found to have actinomyces on the Pap smear, but only if they're symptomatic, you can do an ultrasound to look for abscesses, like a TOA, I guess, and then
mhm.
you will remove the IUD, and then if it grows back actinomyces, then you would treat. So, but
That
if
makes
they're
sense.
yeah, so if they're asymptomatic, you don't have to do anything.
Right.
Yeah. But I think you said you would still give them medication or something.
Okay, yeah. I think for this patient, I honestly didn't do anything. I just hadn't looked up what I was supposed to do for her.
Yeah. Yeah, so that's what you're supposed to do. Just so you wouldn't have you don't need to do anything for her. She's asymptomatic. So,
Okay.
yeah.
Um,
Um and
and that's
then
I think I just counseled her like on signs symptoms for pelvic infection.
yeah,
Be
that's
yeah,
fine.
because it wasn't on PAP, it was on the IUD.
Right, right, right.
Yeah.
Yeah, but like the actinomyces usually only when the patient has an IUD and they will have actinomyces. I think it grows on the IUD or something.
Yeah.
Yeah. Okay. So 23, I also asked you about the DNC. Um, but yeah, but what you said should be okay. You don't, yeah.
Yeah.
And then 20, what is that? 34. 34 is, hold on, scrolling down.
Yeah.
34. Yeah, so since she had a HPV negative, so you just repeat in 5 years. You don't need to do any. Who cares about the PAP?
Yeah.
Yeah. And then 36, we already talked about the leiomyomas. Okay.
Yeah.
Cool,
Hooray.
cool, cool.
Well, thank you.
All right. All right, my turn to get
Yeah.
shitted on.
Hold on, let me find, where did I minimize yours? There it is. Okay. Okay. For patient number one, can you tell me about this patient?
Okay, so this is a 49-year-old G2P2 presented to the clinic complaining of abnormal uterine bleeding. On the ultrasound, we found a 11 centimeter um, leiomyoma in the lower uterine segment. We first tried contraceptives and GnRH antagonist for this patient. However, patient continued to have um, bleeding, and due to the size of the uterus and the fibroid, we decided that she needs a abdominal hysterectomy.
Okay. Had you discussed, what other options had you discussed with this patient?
So for leiomyomas, usually the options are OCPs, IUDs, GnRH antagonists, um, and GnRH agonists, um, and then uterine artery embolization.
Would this patient have been a candidate for uterine artery embolization?
She could have been, however, patient declined that option due to the side effects.
Okay, what were the side effects that she was worried about?
With urinary artery embolization, you can have post-embolization pain, increased bleeding, um, and also sometimes you can have a prolapsed fibroid, and then patient can also develop a fever. Um, and there's also a risk of reoperation or requiring a reoperation or hospitalization from the procedure. So due to all that, all those risks, patient did not feel like that was a good option for her.
Um, for patient number two, um, you had stated that this patient had iron deficiency anemia. What was your workup for her anemia?
Uh, so the patient had uh, the anemia, and patient had no other. I went through her history and physical, and patient had no other medical problems. Um, so we did do a CBC with differential, um, and then also iron panel just to make sure that her anemia is iron deficiency anemia due to the bleeding from the fibroids. So she was confirmed to have iron deficiency anemia, so she was started on oral therapy while we were planning for the surgery.
Okay. And what was your counseling for this patient of her options?
In terms of the fibroid,
In terms of all of her options regarding her bleeding and fibroids.
um, so this patient's age 50, so I talked to her about the risks of her the possibility of why she's bleeding. One is the fibroid. It could also be ovulatory is that yeah, ovulatory dysfunction due to her age. Um, so we initially tried the oral contraceptives so that at least we can eliminate the possibility that it is due to her age. That's the issue. Patient continued to have bleeding, so that kind of narrowed down my diagnosis that the bleeding is most likely from her fibroid, and that's why we proceeded with a hysterectomy.
Okay. Um, for patient number 4, um, can you tell me about this patient?
Let's see. Okay, so this patient is a 57-year-old postmenopausal bleeding. Um, on the ultrasound, we found a 2 centimeter suspicious, oh, not suspicious, 2 centimeter possible polyp. I talked to the patient about an endometrial sampling in the office. However, I did tell her that because of the um, polyp, sometimes we weren't able to get to the polyp to see whether the polyp is malignant or not. So I recommended a hysteroscopy DNC instead. Uh, after the patient were went underwent anesthesia, I started dilating the cervix. However, after some dilation, when I put in the hysteroscope, the scope wasn't really going into the endometrial cavity because I wasn't able to really dilate the endometrium. So at that time, I started having some concerns for a possible false passage. After some attempting to redilate, it wasn't really, I wasn't really getting any progress. We don't have an ultrasound in the surgery center, so I wasn't able to do a ultrasound guided dilation. So at that time, I decided to abort the surgery.
Okay. What did you do for this patient afterward?
So this patient was subsequently taken to the main OR for surgery with a senior partner. Um, it's not appearing on this case list because it was done after the case collection. And the polyp was removed successfully, and it was found to be a benign polyp.
Okay. How did you, when did you can yeah. If you had perforated the uterus and begun your hysteroscopy, what fluid do you use? And what is the max limit, the max fluid deficit?
For me, I always use the normal saline fluids for hysteroscopy. So the max is 2500 cc's. For patients who are on the older side or if they have any type of cardiovascular uh, comorbidities, I usually cap the um, the limit at 1500 or less, depending on their comorbidities.
Okay. What if it was a mannitol or hypoosmotic?
Yeah, so for the electropoor hysteroscope mediums, the maximum limit is 1,000. Um, and then if there's any comorbidities for patients, the max limit will be 750 or 500 deficit
Um,
limit.
yes, I understood. All right. And then for your patient in number 5, can you tell me about this patient?
Let's see. So this patient, 50-year-old G3P1. Um, she came in for abnormal uterine bleeding and ultrasound. She was found to have a 1 centimeter polyp with 18 millimeter endometrial thickness. I took her to for a hysteroscopy DNC, and the pathology came back uh, complex hyperplasia with a tibia. I understand this is the pathologist report, and I understand the newer system will categorize this as a EIN. Um, and that's why I wrote it there as an EIN for this patient. And this patient was subsequently sent to um, the GYN oncologist for further management.
Okay. And do you know what they did?
Yeah, so she had a TLH BSO with lymph node dissection, and she was found to be in stage 1A.
Okay. And what is the treatment for 1A?
Treatment for 1A will be a hysterectomy with BSO, and subsequent basically observation for recurrence with physical exams.
Okay. And for patient number 9, what hormone injection did this patient have?
So this patient went out of the country. She went back to her home country in Mexico, and when she came to me, she said that she had the doctor told her that this medication will help basically help make her feel younger. So she got some type of hormone injection, but she couldn't tell me exactly what kind of medication it was.
Okay.
Yeah.
Okay. Um, Let me see what my other thing was. Okay, for patient 15, can you tell me what is the management for what are the management options for adenocarcinoma in situ on an ECC?
Uh, so adenocarcinoma in situ, it depends on the patient's age, whether or not she still has desire for future pregnancy. Um, for someone who is younger and has a desire for future pregnancy, usually you can do a cone excision biopsy, and if the margin is negative, you can observe the patient with uh, pap smears and colposcopies. However, if the patient is done with childbearing, the recommended management is a hysterectomy.
Okay, and after the hysterectomy, how long would you continue HPV based testing?
After the hysterectomy, the patient should have monitoring for 25 years with beginning with yearly co-testing. If they're all negative, you can space it out to every 3 years for total of 25 years.
Yep. Cool. I think that was all my questions. Yeah, that was all my questions.
Okay,
Yeah, so
cool.
the ASCCP, um, oh, you have a perf too. Well, okay, well, we'll do that one another day.
Yeah.
And, um, so for adenocarcinoma in situ, the ASCCP says HPV testing after hysterectomy for 3 years, annually for 3 years, and then every 3 years for 25.
What
Um,
was the management for, like, if you're still want kids? Is it
Yeah.
just a cone biopsy and then you do PAPs
Yeah,
every 6 months?
it's cold knife cone, and then but if you're doing a leap, then they do a leap with a top hat, but that's not recommended. Cold knife
Right.
cone
Yeah, cone knife
um
cone.
is better. And then code testing with endocervical sampling and HPV testing every 6 months for 3 years.
Oh, six
Um
months.
yeah, for and then they can go to annual for 2 years until the hysterectomy.
Wow.
Um If the hysterectomy is not performed and all testing has been negative for 5 years, it's reasonable to space out the surveillance to every 3 years, but the data is limited.
Okay. Cool.
Um,
Yeah. So interesting for this patient. So I sent her to oncology, right?
yeah.
And so I was trying to see like what he did for this patient. So he did a DNC and sent it to frozen.
What?
And right. So she said and then that came back negative. So and then he just did like a TLHBSO with um with no lymph node dissecting. So I'm just
I
like,
have to be.
that's very confusing. I don't know why you did that.
That's weird. I don't know why he did that either.
Yeah, I mean she
I,
does have postmenopausal bleeding, so I would see why you would do a DNC, but I thought you're supposed to get a cone knife cone to make sure it's like everything's good before you can do a hysterectomy.
um,
Like to
I that's what I would do. I mean, you can
like a
go straight to hysterectomy. I don't think any of us generalists do because we're like, well, if it's cancer, if I see AIS, I already refer them out.
yeah, exactly.
I have one patient who has AIS on the hysterectomy, but it's her PAP was negative.
Uh oh, I mean PAC
That was
doesn't pick up everything.
right. So, but yeah, you can go straight to hysterectomy, but I don't know
Can
why
you?
he did it. Yeah, with AIS?
I thought you're supposed to like repeat a cone to make sure there's no skip lesion or like your cervix, you got all the stuff on your cervix. But
Uh, I'm going over to the ASCCP.
because I remember reading that.
So ASCCP says that here, I'm gonna send you a screenshot.
Oh, yeah, just send me the link to
Oh, it's on the app.
oh, you're okay. Yeah, just send me a picture.
Um, so so it was the ECC. Yeah, that's interesting. Yeah, okay. Actually, it does look like you're right. So what it says is diagnostic excision procedure to rule out invasive cancer.
Mm-hmm.
And then if the margins are negative, you go to hysterectomy.
Right.
Or if the ECC is positive, then you can repeat an re-excision, and that even if the hysterectomy is planned. Yeah, I don't know.
Yeah, because it would make more sense if he had done a cone knife cone and sent it to frozen, right? Send it to
Yeah,
frozen, and then if it comes back negative, then you can do the
yeah, I
TLHBSO. Whatever.
don't know if they did that.
Anyways, all
That's
right.
weird. Um, yeah, I mean, if they ask you, at least you'll be able to say guideline recommends an excisional procedure to determine um, invasive disease. However, in this case, after referral, he performed hysterectomy. Yeah, you'd be like, I referred him. What do you want from me?
Yeah,
Um,
exactly.
and then I think you answered number 9 well. I think that you can say, this patient received a hormone injection of which she did not know, but she was hoping to treat her symptoms was unaware if it was bioidentical or what was the medication. And then you could say, and then we did the biopsy.
Yeah. I think it was
Um,
just progesterone. It was like a, I think it was just like a depot shot. I feel like she got. And
she
then
got it in the ER.
no, 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 no. She went to Mexico and some doctor gave it to her.
That's just a fucking weird thing to do.
I feel like that's people do that because like they don't. No,
She
it's like the Wild Wild West outside of the U.S. You just do whatever you want. Just like, oh,
oh,
you want to feel younger? Here's some random injection.
because I'm like, I've treated bleeding in the ER with a depot, and then I'm like, but you need to come to the office for a biopsy.
No, no, no. She didn't have bleeding. It was after the
Until
injection she started having
that's
bleeding.
really fucking weird. But I guess you're right. I guess I don't like know what's going on in Mexico.
Who knows?
And then, um, I think for patient number 4, probably just ask how you counseled her after, but it's good that you were then later able to do it.
Yeah, I mean, counsel her. I mean, I would just say like, oh, I didn't feel like it was safe at the time to continue proceeding. Um,
Yeah, I think that's exactly right. I think that you would say, I let the patient know that I was unable to perform the procedure secondary to concern that I was not in the right location. I didn't wish to injure her. Um, Given, those risks, we decided to anything change between then and then the time that you were able to do it? Like, did you do a vaginal estrogen or anything?
um, I didn't do that for this patient, but we just literally just needed a ultrasound to guide us, basically. It
Oh,
wasn't
all right.
like, yeah.
Yeah.
I mean,
Um,
I see her cervix, and I give everybody Cytotec or anybody who's postmenopausal Cytotec before their hysteroscopies. Um, but yeah, for her, it's just like weird.
oh yeah,
Uh,
I think I did cytotect to that one patient. Okay. Yeah, no, that's fine. I think that they'll just ask you about it. Because I
yeah,
think that the question for this is it's like it's good that you bailed. They'll ask you what did you do after, which is informed the patient,
yeah,
and scheduled her for a day with ultrasound guidance, which was not available at that time. And then they can ask you about like risk factors for perforation in the fluids, but you have a
yeah.
perforation, so they might need that.
But I think you're correct though. Like, because there's a no, not a practice bulletin, but like a committee opinion about giving them estrogen for 14 days, and then on top of that, you give them Cytotec. It will
Yeah.
increase the success rate.
Um, but yeah. But yeah, I think who even knows if they'll even ask a fucking question.
They probably
Um,
will.
but I'm like, yeah, I mean, how many pages? You have 16 pages? Oh, like from mine, I don't fucking know what they're gonna ask.
Yeah,
Then for patient number 2, when it comes to the workup for anemia, I think I would. Your answer was good. I think it would just try to make it maybe more concise. Like if they ask, you can say this patient does not have any history of anemia throughout her life and no family history of anemia.
mm,
As a part of our initial evaluation of her of her abnormal uterine bleeding, we did a CBC. After identifying the anemia, we did a iron panel as a part of the study. If she'd had family history of anemia or personal history of anemia, I would have, you could say I would have evaluated uh, genetic causes. However, our next evaluation was a ferritin level, which indicated iron deficiency. So I think I would just put in that she didn't have a personal or family history.
yeah,
And first step to evaluating her abnormal uterine bleeding included a CBC, and the next test was ferritin.
Yeah, that
And
sounds
if
good.
because if they're like, well, what else would you have done? But you can say like basically
Yeah,
by
it's
saying
basically like anemia in pregnancy. It's the same thing. Like you have to
right. So
rule
that's
out
if
everything.
exactly. And so if you say she didn't have a personal or family history, you've knocked out the thalassemias and like whatever.
Right.
So I would just add that line in so that they
Mm-hmm. Yeah, that makes sense.
can't. Then
CBC. Because I wasn't sure if you were trying to ask about the palm colon for the bleeding. Um,
no, I think I'll expect them to ask what's my differential, but you have the leiomyoma.
okay, yeah.
But yeah, I think it's good to be able to prepare for that. And then I don't know if they'll ask about uterine artery embolization. There are GnRH agonists and antagonists. Um, and then for uterine artery embolization, the other thing that can be a problem is they can cause ovarian insufficiency.
Right. I mean,
But yeah,
that's
otherwise you crushed all of those side effects. You nailed it.
I probably missed a few because they're so long.
Dude, I have the practice bulletin up. You nailed it.
Oh, really?
I was like, oh shit, okay. I was like, great, that's where I'll be a month before the exam. Okay, sure, okay, I can. All right.
Yeah, you have
Uh,
time.
yeah, like sure. Fuck. Um, yeah. So I think that was all. I
Yeah.
think I. What's so hard is that we're assessing each other, but I'm like the way that you've answered, like I think that you would pass all these. Oh, what was the question that I nexted? I don't know.
The the can you do that? Next.
I think you can.
You can?
I don't, yeah, I don't. Cecilia said that she did that, but I don't know if it's during the structured cases.
Oh, okay. That would make more sense. Be like, next question.
Yeah.
But I feel like that's kind of rude, no?
I mean, they can't count it against you. They can count a wrong answer.
That's a candidate is rude minus 5 points. Whatever.
Candidates a That's, yeah, I can't remember what the question was.
No, it was the frozen one. I
Yeah,
asked you about
okay.
the percentage for the frozen.
Um,
Yeah, we'll have to look it up. I'll look it up after.
sample tissue detection. Because I think that they mentioned it in the exam pro and that it's like flip through my notes. And it's like 80 something percent.
Okay.
But
Frozen most.
that's I'm trying to find it.
Frozen section. Let's see. I guess it also depends on the type of tissue too.
Yeah, like but yeah, I mean I think that how I answered is literally just going to be it's not my standard and it's not ideal. However, given the patient declining an in-office endometrial biopsy, I'm using the resources available to me to determine whether this patient is a candidate for an ablation. While recognizing its shorthand, I discuss with the patient that this is not Frozen is 88%.
Oh, okay. Where did you find that?
In my notes from the exam pro.
Oh, okay.
Oh.
The
And I don't.
that's the frozen for use in general, frozen.
That's. It looks like that we were talking about EAC. So I think.
Oh, so probably
Oh,
like lymph node. I mean, not lymph node.
yeah, no, but it looks like we're talking about endometrial sample and
Oh,
endometrial.
endometrial. Probably sending frozen for the uterus.
Um, may have just been all of the endometrial tissue because it's also EIN, but it could be all of the uterus.
No, no. I mean, like when you know how like you send the uterus for frozen before you decide whether or not you do lymph node dissections.
Yeah.
Um, what Alsawi always does. Okay, at least you
Um,
have a number to
yeah.
tell them. 80%. I mean, that's pretty accurate, I guess.
Not bad. I mean, it's not
Yeah.
great.
Uh-huh. Yeah. Okay. So yeah, I mean, you just have to find some answer basically in case they ask
Yeah.
you.
Evaluation of frozen section with abnormal bleeding.
Frozen
This was a
section.
study, and they saw, yeah, between 88 and 96. All right. All right.
Oh, okay. Yeah, I mean, I just looked up some random article says
Like,
frozen
on a,
section and histological pathology is like 90%.
yeah, and I just saw a study that said that, so. All
Well,
right.
yeah.
Great. Great.
And all right. Okay. Well, when the you want to do sorry?
Yeah. It's the whole like it's better than the patients that I don't have anything until after.
True.
And I'm like, please don't fail me for my malpractice.
No, no, think about it. That's just one that's like 1 point. Like you might miss like I don't know how to score your case list. That's 'cause like it could be any question, the questions could be from anything. So like how are they grading you?
Right, what I just don't know is like, would they look at all of my ablations and all of my ablations without sampling?
So like is that just 1 point or is that like each time
Yeah.
each time you didn't do it it's like 1 point?
Like that's because it's like, yeah, I mean,
Yeah. So how many points do you have to go go negative? I'm just kidding. You won't. You
this
won't.
bitch. But that's like, I think as long as I'm like, look, they fucking, I can't force people.
Mm-hmm.
It's fine. I'm just gonna be the very best
Yeah.
counselor ever.
All
Gonna be great.
right. All right, my friend.
All right,
That's
have a good night.
you wanna
Good luck with
you want
bedtime.
to do Thursday or so or
Yeah, yeah, let's do Thursday. We'll do office.
okay. I'm gonna be on call, so I might or might not be busy, so just
Yeah,
heads
well,
up.
that's fine. Yeah,
But
that's fine.
we'll shoot for 7 still.
Awesome. And
Yeah.
yeah, if it's busy, we can always reschedule.
Yeah. Okay, sounds good.
All
All
right, talk to
right,
you
see you
later.
then. Bye.
Bye.